know we're starting to get tired. And we've used a lot of thinking brain cells today, right? I know I've learned a lot. And it's hard to concentrate all day. But I think that we had some dynamic speakers, so I'm really excited. Well, we're in the home stretch, and we've saved the best for last. We're going to have this amazing panel. But I'd like to first have Alicia Berkmeyer, who's in the room with us today, come up. And she's going to say a few words about the work that's happening about behavioral health integration in Arkansas. And I have to say, I've known Alicia for a few years now, and when I first met Alicia, she had invited me to a CPC Plus stakeholder meeting. And I remember meeting her and thinking of all these amazing, innovative ideas, talking about innovative health projects. And one of the things that they were talking about was behavioral health integration. And she had asked would I be willing to co-lead a work group on behavioral health integration. And I remember looking at you thinking, oh no. And here I am. So Alicia is passionate, she is committed, she is dedicated, and the work that she does in Arkansas is truly amazing. And so I just, as I look over it and think about her and think about the vision that she and Blue Cross has, it's so exciting. And it's so exciting to think about all the programs that are going to be happening as we start moving into these next phases. We heard from Adele today. Healthcare is changing, and it's changing rapidly. And so I'm so grateful that we have leaders like Alicia, and she's the Executive Vice President and Chief Health Management Officer for Arkansas Blue Cross Blue Shield, who's really leading the helm. And so with that, I'm going to turn it over to Alicia, and she's going to say some words about what's happening in Arkansas Health.
Thank you, Kim. And I also want to say thanks to each and every one of you here in the room. As I think about today and I think about what's going on, each one of you is accountable and responsible for improving behavioral health in the state of Arkansas. So thank you all for being here and doing everything you're doing to make improvements. It's an honor to be here with all of you, and certainly, Kim, I also reflecting back to that sitting in the meeting room at Arkansas Hospital Association, whiteboarding what are the challenges and what are some of the things that need to be addressed, and certainly behavioral health is one of those key areas. You know, behavioral health has been a challenge, but always, magnified by COVID, has really brought a need and a challenge to our state to improve the access to care. When CPC started early on and CMS said we need to have integrated behavioral health, we need to have that in a clinic, in the primary care offices. That was a real challenge because back in 2012, 2013, that was not something that was done on a regular basis. But yet it is so important, and over these years that we've looked at behavioral health, we've worked towards behavioral health, we can see that if you don't address the behavioral health, physical health will not improve. So it's got to be seen together. So working in the team-based care is very important. So it's an honor at Arkansas Blue Cross and Blue Shield to support this conference and to work beside Arkansas Behavioral Health Integrated Network, and also these amazing clinics that are sitting here at the table that I'm very proud of, to see the work and for you to hear about the amazing work that they're doing, because they're the innovators. They're doing things differently and better than have ever been done. They're working on new ways and methods to take care of patients out there from a behavioral health perspective. So certainly glad to be here, and I'm going to have the honor of reading a little bit about each one of the individuals that you're going to be hearing from today. So we certainly have an outstanding panel with us today, and each of these are champions in behavioral health integration, and that very much importance of behavioral health in the practices. Each one of these is doing a special or a unique way of addressing that integration in their clinics, and you have the first opportunity to learn and hear from them today. Certainly, I would be short if I didn't also thank, and really the leadership that we have here today with Dr. Gibson and Kim. Their energy, their support, and their excitement and integration for our state of Arkansas really has brought attention outside of Arkansas as well. I can tell you from a CMS perspective, many times have they asked to speak and learn more about Arkansas Behavioral Health Integrated from a national perspective. I'm going to do my very best because my excitement could continue for much longer. But I want to go ahead and start with the introduction of the clinics here. First of all, we have Derek Lewis. Derek is the Quality Care Director for the Arkansas Primary Care Clinics, and he is also the founder and president of DL2 Consulting, which DL2 Consulting was established in 2012 and provides strategy, marketing, business development, and performance improvement solutions to clients in the healthcare and nonprofit sectors. Derek also serves as the president of his family's private foundation, the Derek Lewis Foundation, whose mission is to improve community health by addressing health disparities and collaborating with healthcare thought leaders to improve health equity in the state of Arkansas. Next on the panel, we have Dr. Jason Lofton. Dr. Lofton has been practicing family medicine in DeQueen, Arkansas for 16 years. He is a local medical director with Alliday ACO and has been participating in the Arkansas Behavioral Health Integrated Network projects for 2 years. Dr. Watkins served as a county health officer for Sevier County for the past decade and has helped lead Sevier County through the COVID crisis of having weekly meetings with various leaders in the county. He has been a leader for integrated behavioral health workflows to address substance use disorders, chronic health conditions, and mental health conditions. The next clinic we have represented by Julie Carman-Calvery, Behavioral Health Clinic Director and Site Provider at Boston Mountain Rural Health Clinic. Julie joined Boston Mountain in February of 2021 as a psychiatric nurse practitioner and transitioned to the clinic director role in September of 2022. In addition to seeing patients, Julie provides administrative and clinical support that fosters quality care, provider education, collaboration, and team building. Julie helps focus Boston Mountain efforts on true rural health grants partnered with Arkansas Behavioral Health Integrated Network and has been a champion for behavioral health integration in their clinic. We move on then, we have Sarah Watkins, a nurse care coordinator at Vanna Medical Associates in Northwest Arkansas. Sarah works with physicians to provide quality care through the engagement and education and has been instrumental in making progress towards behavioral health integration and is a true champion at Vanna. She identifies patients who are at risk for certain diseases and recommends appropriate preventive care, and she also helps patients coordinate wellness visits, age-appropriate health screenings, and referral to medical specialists. And next we have Christina Smith. Christina is a quality care and behavioral health supervisor, as well as process improvement director at the Prime Care Medical Clinic. Prime Care has been very active in integrating behavioral health services with their medical clinics for more than 5 years. It is Christina's responsibility to continue the growth and the improvements of behavioral health integration and the continuity of care between the medical teams, behavioral health teams, as well as contracted providers to provide the most effective care possible for the whole patient experience. And last, but certainly not least, we have Pennie Biggerstaff, the clinic administrator of the North Hills Family Medical Center. Pennie has 32 years of experience working with primary care and specialty independent practices. Pennie has been a true champion to behavioral health integration in her clinic, and she has facilitated transforming the primary care clinic into a patient-centered, team-based approach to delivering care, with a focus on improving patient engagement and health outcomes. So please join me in welcoming this great panel.
Thank you, Alicia. Thank you all for being here. I'll go ahead and full chair.
Well, I just told this panel, we are really proud of them. And if you listen to who they are in different roles, different places in the state. And so these are some folks that are really walking the walk. So we're really excited to have them here. And so you've heard their names, but if y'all don't mind going along and give a brief introduction of yourself, your role, your organization, and the setting that you're in, and then just a really brief, what does BHI, Behavioral Health Integration, look like in your setting?
My name is Sarah Watkins. I'm a nurse at Mana Family Medicine South, and I'm the care coordinator there. I've been a nurse for 17 years. I started out as a baby nursing. Most of it has been in family practice, and to be honest, psych nursing always scared me. Mental health, it was nothing I was interested in working in. I didn't have good experiences in clinical rotation, but in 2016, that all changed. My sister, at the age of 29, completed suicide, and it was a very hard blow for me. I had no idea that she would ever do anything like that. But looking back, I could see that there were warning signs, and I just didn't see them. So when I was offered a care coordinator position with Mana in 2017, which included behavioral health integration, I was interested for personal motivation and professional. So my clinic did not have any behavioral health integration when I started. They basically said, here's a big binder about CPC Plus. We don't really know what your job is or how to implement it, but here, and watch some webinars. And so I was like, oh my. So it is taken off. We really do well at the clinic because I have a great supportive team. But yeah, that's me.
I'm Jason Lofton. I'm a family physician in Dequan, Arkansas. I've been there 16 years. My role in behavioral health integration started really with CPC Plus as well. That was one of the opportunities we had in that. I had a friend who was a counselor. He lived in Northwest Arkansas. He drove down once a month. I would line patients up to see him in my clinic and used the funds from CPC to pay him. That was the first time I was able to bring somebody else in. I've always taken care of patients with depression, anxiety, and various behavioral health problems. And so once my friend got busy enough with his own practice and counseling, that stopped. And then not too long after, I've been contacted to become part of ABN. And then this past year, I've been able to have a student in my clinic that's a counseling student. And that's been a really big plus for me. She's there 3 days a week, and we can talk more about that. But that's kind of the next step, is trying to get somebody there full time in my clinic.
Thanks for the opportunity to be on this panel with such great people. Derek Lewis, I'm the Quality Care Director for Arkansas Primary Care and Oklahoma Primary Care. Actually, my father is the other Derek Lewis. You can tell him I said it. He is the founder and owner of those clinics. So I'm probably the most non-clinical person up here, I think. But my role has been to, I'm over the quality, so I'm over all the value-based programs, and just like my colleagues, sort of this integration started with CPC Plus. And I think where we are as a clinic is probably ever evolving. Matter of fact, I work very close with Dr. Pennie on several initiatives to in the CPC Plus arena. So we started out with an intern working with UCA. I think we had somebody from EULA. Obviously, in the CPC Plus, we had compact agreements with a couple of different agencies. And then I think the last stint is that we had someone in the office a couple of days a week and seeing how that worked. I think where we're probably headed towards now is doing more telepsych and then still having someone come into the office. It's challenging. We're a very high-value clinic, and we've been in value-based care management for a while, and so getting our clinician staff to catch up with some of that is challenging. But I think the last time Dr. Gibson was at the office, I think Dr. Lewis kind of started to see the light a little bit. So it's, as Ms. as Dr. Little said, no, she's provided hope.
Hi there, Julie Carman, and I'm the second P, and I also work as the Behavioral Health Clinical Director at Boston Mountain. We're actually a little different than the other settings. We are at QHC. We have multiple campuses spread out in northwest and north central Arkansas. What I do is behavioral health integration, pretty much. That's my job. And so what that looks like for us is very different than others. We see mainly rural patients that are underinsured, uninsured, very limited access to care, and we have our own behavioral health department inside with the medical, so it's co-located. We consider it to be collaborative care, which I know is probably a little play on words, but we have therapists, we have psychiatrists, we have psych MPs, so it looks a little different, but we have a closed system, so all of our referrals come from our PCPs within our system, and we have access to face-to-face services also through telehealth, and then we also have a rapidly growing MAP program, and we're also working with school-based centers and putting some of our own in actually to work on lots of different behavioral health integration. So it's a little different, but that's what it looks like for us.
My name is Pennie Biggerstaff, and I work at North Hills Family Medical Center. It's a primary care clinic in North Little Rock. For us, I would agree with the other people on the panel. CPC Plus probably was very instrumental in bringing the behavioral health integration to the table, really to our forethought. Not that we didn't recognize some of the needs on our own, but it really started the thinking process for us. The way that behavioral health integration is kind of looking for us is we have brought in social work interns, and we've worked very closely with ABIN to help with training for our staff and for us to be able to look at things differently. But we've also taken a very practical approach in regards to really ramping up the way that we do care management, chronic care management, the way that we have involved our physicians to really be engaging and doing warm handoffs to the different things that we have developed so that we have improved patient compliance. And we really took the team-based care approach kind of to another level. We really involve our entire staff. If we do training on certain things, yes, our clinical staff will get more in-depth training, but our receptionist, everyone on the team is involved in training of everything that we do around behavioral health so that we're all engaging with the patients. We're trying to increase patient engagement. So we do a lot of patient follow-up individually. We also do group classes for certain groups of patients. That's been very successful for us. We really try to work on resources for patients. We take care of some transportation ourselves. We do medication management at the home for some of our patients to make sure that they're staying on track with their medications, and have really increased our screening process with the PHQ-9, GAD, substance abuse, so that we can be more aware and try to get our patients identified so that we can really reach out and start to help them. So we've started small, and we're really taking a very individualized approach to our patients and really trying to engage with those patients, and hopefully we're having one success story at a time as we continue that engagement.
My name is Christina. I'm with Prime Care Medical Clinic. Public speaking is not my thing, and as we also know, this is really difficult. A little bit about what Prime Care gave to me, and then they gave me the opportunity to be a part of such a great group of people that are pushing to make better changes so that we have the collaborative medical and behavioral health together in the same facilities. I've worked at different medical facilities before. I've been with Prime Care for a little over 5 years. And I thought I just wanted a part-time job. So I started as a receptionist, and I was like, listen, I think I want to stop with the management. I want to take a little break. I just want something but I don't know how to do something and do it partially. So I went in and I got excited and I was like, hey, these people are cool. I'm really into this now. And so from there, I got opportunities, and the greatest part of being at Prime Care are the people that I get to work with. Prime Care has an owner. His name is Dr. Warnock. In 2017, because he was having complications with his patients being compliant to referrals when we would refer out to counseling, or the waits were really long, or not being able to get maybe progress notes back from when we send patients out, he really wanted to make a change in his clinics. He has 4 clinics in Central Arkansas. We have 2 in Searcy, 1 in North Little Rock, and 1 in Searcy, 1 in North Little Rock, and 2 in Conway. And each one of them, over time, he invested, and he put counselors in each one of them so that the patients would be able to have not only the medical side, but also the behavioral health side, treatment all in-house. He's continued to grow that and he's allowed me to be a part of it. So I want to give appreciation where appreciation needs to be had. Today I have some of the counseling team here with me, and they could have equally been up here, and I'd have been absolutely fine with that. Alicia Wingfield is our counselor at Conway. Marvin Eady is our counselor at North Little Rock. Our 2 from Searcy wasn't able to make it today. Dylan is one of our interns, and then Amber Hug as well. She is one of our Searcy counselors. So we've been able to have a collaborative team, and the need was there because our owner saw it, and him as a doctor, he wanted to make sure that he was providing the best care to his patients. So that's a little bit about Prime Care and why we do counseling.
All right. Oh, thank you, Derek. I'm gonna turn this on. Thank you all. And as you can see, we have a wide variety, right, of behavioral health integration. And so one of the things that we really wanted to emphasize today, that behavioral health integration goes across a continuum. And so it's not a cookie cutter. It looks one way in all of the clinics. All of these different settings are doing something just a little unique and something a little different. Everyone has different resources, different staff, different champions, different reasons for doing this work. And so I think that's important. That's an important takeaway for us today. We want to talk a little bit now and hear from you about what needs did you see in your clinic, in your population? What were patients talking about when they came in, or what were you hearing from them that made you think, you know, I really need to start addressing the behavioral health piece? We can start with you, Sarah.
Well, I would say that I focused first on depression and anxiety and targeting my higher PHQ-9 scored patients because I felt like they would be good group to start with. And so I taught myself, I did a lot of research and created a depression and anxiety self-management toolkit. And then I would reach out to them and offer this free session. I said, I'm a nurse, so it's going to be basic, simple stuff, but just good refreshers on how to take care of yourself emotionally. And so that started within the first year of my care coordinator position. So depression, anxiety, and then of course, I'm a nurse, so diabetes, which is huge. Because there were so many out of control diabetics. And what I found is there usually is a behavioral health component to why their A1C is so high. They're emotional eaters, or they're depressed, and so they don't want to get out and exercise, or they're so depressed they forget to take their medicine. So I do see a lot of diabetic education patients in my office, but I usually touch on mental health as well, because that has to be a part of it, especially new diabetics. I always say, this is stressful. I want you to realize that I know how you feel as far as this all being overwhelming. And so take it slow. Do something for yourself every day that makes you happy. Focus on your emotional health as well, because I don't want you to have what they call chronic disease burnout, where a patient stops all their meds, stops everything they're doing, and just forgets it all. Because I've seen that too, and then I've seen them in the hospital with a stroke and a heart attack. And so yeah, I found that it wasn't just one diagnosis, but all across the board. I see people can't talk, people for weight loss strategies. Yeah, and of course, I've also had the pleasure of having a behavioral health intern from the U of A, and she's been amazing. She's been seeing so many patients since last fall. So the needs kind of change as every day. But why did I choose it? Well, it was a requirement of CPC Plus. but also I wanted to make a difference. You know, my job isn't always fun. It's a lot of metrics and analytics and closing gaps. But the fun part of my job is educating patients, making a difference, seeing their eyes light up and say, yeah, I can do this. This doesn't look that bad. Or you know what, I do need to go exercise. I know it makes me feel better. I'm like, let's make a specific plan, and I'll call you in 2 weeks and see how you're doing. So that's why I do it, and that's the good things that I see from it.
Yeah, so in my clinic, I've been a solo practitioner, been by myself up until last year, hired my first nurse practitioner. I've always, I guess, seen the need. I would treat patients, felt in small town Arkansas, you kind of have to get comfortable treating patients because we don't have a psychiatrist we can send them to. And we're trained in that in family medicine fairly well. For the, there's some severe cases that we do need help with, but I would also see the data that cognitive behavioral therapy or counseling is equally effective as oral medication. And so if those two together can work synergistically, then we're missing a component, and patients don't want to drive an hour. Texarkana's the nearest town that has more significant counseling than DeQueen, so you could refer people, but they're either not going to go or they can't go because of transportation issues. So when the CPC program, again, it kind of was the spark. So, okay, I've got to do something just to be a part of the program and use the funding to bring a counselor in. But I saw the immediate benefit of having that, whether it be a warm handoff or the days that the counselor was there, I could just have the patient see me and then go see the counselor, or have the patient has a name saying this person's going to call you. When COVID hit, we were able to do more of the telemedicine counseling, and it was successful. I did have one patient, that a gentleman I was seeing, I was really having trouble finding a medicine for anxiety that would work, and through the counseling, I don't see the guy anymore because he basically, through the counseling, got healed, and he doesn't have medical problems that needs to see me on a regular basis. And so that was the first one of the kind of scenarios where I said, hey, this really, the medicine didn't help this guy, the counseling did. And so from there, that's just been a desire to try to get that fully integrated. And then when I became a part of ABN and then had the opportunity, and thankful to Blue Cross helping support that grant, that's really been even more eye-opening. There's been some cases we can probably share in a little while of just how having that more consistent person there. I have patients that are wanting to see the counselor, not necessarily see me. That's just really what they need. They don't need, their diabetes is in control, their blood pressure is controlled, but their anxiety or depression wasn't, and that was a more pressing need. And so by having somebody there, it just makes it easier for the patient to come to one place and not feel like have that stigma of going to the counselor's office that might exist. They can come to my office and still see the counselor and get that holistic approach all in one place.
Thank you. So similar to what my colleague said, we start out with screening, depression screening, anxiety screening. So I'm quality, so I'm the gap closer. I got to figure out how to close gaps because that's the only way we're gonna get shared savings. So I'm the non-clinical person up here. Shared savings is what I am judged by, whether I'm responsible for it or not. But so CPC Plus really, as everyone has alluded to, sort of put us in the sandbox to think through this. And what I started noticing, and so while I'm over the matrix, the back part of that is once I audit our stuff, and I'm auditing workflows, right? I'm auditing, it used to be close the referral loop. So I get to audit those things. And so I'm really trying to figure out how do we eliminate the bottlenecks in our system. And what I noticed was, I think Stacey alluded to, is that the non-compliant patients on our chronic disease side often had some type of behavioral health issue. And so I started doing clinical interviews with my providers. I was with my father and Dr. Bullock and our nurse practitioners to understand, how that correlation worked. And so after interviewing them, I started interviewing our front desk with irate patients come in. And so we had to do this training with front desk, had to do training with clinical staff, and everybody sort of buy into that behavioral health is not an offshoot, it's not something that's in the corner somewhere, but it's really part of holistic medicine that we gotta pay attention to. Now my role is to think through the workflow part of that and how our systems all integrate into that, but really thinking clearly that this is not something that should be in the corner and it's not just a referral and we take our hands off of it. And I think that's very important. But our patients were telling us that. Even as we were attempting to do some of these innovative things, what our patients were really telling us, I don't trust that intern, I trust Dr. Lewis or I trust Dr. Bullock. And so if we're implementing, if we're really trying to do integration, it has to be full integration where the behavioral health provider and the PCP are really engaged in that patient's care. And they're on the same page, right? Again, it can't be just a refer off and everybody sort of goes away. And so what we learned as we had folks in the clinic is really to get them to be part of the tribe too. Because if our staff doesn't trust them or doesn't have that relationship with them, then our patients wouldn't either. And the last piece I was saying, our patients want to be educated, and we got to be very careful of boxing folks in and stereotyping people. A lot of patients, as non-compliant as they may be, they still want to be educated and provided resources. And they want to be heard. And this is part of the front desk staff, and I'll lead us along, part of our sort of educating our front desk. Every person that comes in is probably sick, so they're probably not on their best behavior today. And so we got to give a whole lot of grace in these areas and think through if this person hadn't been on their diabetic meds or hypertension meds, it probably is going to be some type of behavior issue today. But that doesn't mean we villainize those patients, but we, again, look at it as part of the total care.
I think for us, just the population that we serve and the difficulty getting people into appointments is a big piece of what we see. So you refer out to a therapist, how long does it take? This patient needs help now, they don't need help in 6 months. And that's a huge challenge that I think really pushed us in the direction pretty quickly. Another thing was just the barriers that patients have to even getting to appointments, whether it's transportation, finances. There's a multitude of things that can be barriers for these patients. So being able to have everything in one house, it really allows our medical docs to be engaged with the behavioral health team. It allows everybody to have access to records. I think that was one thing our medical docs felt like. They felt just cut out of the loop of not being able to provide for that whole patient because everything was kind of a mystery on the behavioral health side. And so how are they? What's going on? I don't know. And so that was something that the medical side really felt like was important and really kind of led the way for that integration.
Thank you. For us, I think some of the things were similar to what others have said. We were having access issues and wait times for our patients that we just felt like were not acceptable. And we had been, our clinic, as we developed and did this transformation to team-based care, had been very successful with diabetics and high blood pressure patients. And we did notice, like others have said, the issue that there is that correlation. But from a practical standpoint, I stood back and said, if we can be this successful with these patient populations, then we should be able to be this successful helping patients with behavioral health needs and looking at the patient as a whole, top to bottom, and trying to figure out how we can do better at this. And what we were noticing through the development of our care management and the development of training our staff and the engagement that we were having is that our patients liked getting their services from us. We had already started, as our doctor said, de-referring. We weren't referring out for diabetics like we had before. We were getting better results having group classes and doing those things ourselves, and we're really engaging and building that confidence with the patients. And so once we started really looking and seeing doing a deep dive and seeing the depth of the issues that our patient population was having that maybe we really had not realized and we had not been giving adequate attention to, we started getting this positive feedback from our patients and just thank yous and hugs and small successes for themselves or family members that were coming to our clinic. We had one patient that begged for us to please not take her off care management. She knew she had met all of her, busted through all of her barriers, had all of these improvements, but she just loved the contact with us and loved what was happening and did not want to be released to just her regular appointments anymore. So, and just seeing the way that my staff was responding. It's great to see your staff walking down the hall and they're giving each other high fives because we just had a huge success with Mr. Smith. And so just seeing how the staff were engaging, how the patients were responding, and then as our physicians started seeing this, then they were like, bring us ideas, and they just kind of stepped back and let us get a little creative. And so that made it fun for the staff as well, I feel like, as we just developed some things. I'm a thinker. I can overthink things, and I want the whole plan put together, top to bottom, and then I'm going to communicate it. And our care manager is a doer, and so it's been a really good balance because she was like, you can sit here and think, Pennie, and make all your list, and then I'm going to go figure out how to address these three things with these patients that I saw today. And so kind of blending that combination of the two of us, and it really opened my eyes a lot to the needs that we had with our patients, and I've been real excited about the results that we've been seeing.
So I think for Prime Care is a lot similar to a lot of the things that they have said already. We have been we were a part of CPC Plus, PCMH, with Blue Cross Blue Shield, and Medicaid, and then now PCF. They did push for lots of process changes in the clinics and for us to monitor our patients in certain ways. Without that, I do say that Dr. Warnock and his team already saw some issues. It wasn't quite outlined as clearly, and then when we started implementing some different material into the clinic for the patients and to monitor and to track them, we were able to see it clearer. So the reports that came back from the insurance payers and things like that, we were able to see, we're making some changes. We were right here, and then we did this, and now we've made these changes. The same kind of stuff happened with the counseling. So without those incentive programs, we wouldn't have been able to fund counseling. First of all, I wanted to say that. And then we did learn, after putting counselors into the clinic, that having a patient-provider relationship is beautiful. Your patients come back in, they know their doctor, they trust the clinic, They trust the treatment plan. And then when you tell them, hey, I'm going to refer you out to go see this person over here, there's a really long wait, but this is really important. You really need to do this, okay? We knew that there was an issue there, and the patient wasn't getting their full treatment. So then you have a provider that comes in and you say, hey, we have a counselor here that works with us. They're a part of our team. We would like to know if you're comfortable. They could just step in for a few minutes. I know we've discussed this side, but sometimes this side is also connected to that side, medical to behavioral. So that has been something that it has just naturally happened, and we've learned that it really benefited the patients, really benefited the clinics. It helps our patients with stigma. I think that this is kind of fading away a little bit, but early on, people didn't want the stigma of saying that they were going to counseling. They didn't want to pull up at a counseling facility. We would get a lot of pushback from it. Well, they come to their doctor's office, and they get both. So that was a plus. Our counselors and our quality care team together started to implement different screening tools for our patients on a regular basis. We started to see more ways that we could recognize when they were needing more behavioral health services through like our social determinants of health screenings that we do. And then our counselors, specifically Alicia, our social worker counselor, she helped put together resources that were amazing with the quality care team. I mean, just together. And then it didn't only benefit the patients, it benefited the employees, because the counseling team as a whole has put together trainings. They've gone to the clinics, done whole trainings, so that from the receptionist to our techs, to our nurses, to our providers, all the way to the counselors. If the counselors are in a session with a patient, our whole team knows what to do. They know how to take care of that patient, make the patient feel comfortable, until we can get them in to see the counselor. So that is why Prime Care has found benefits in adding a counseling team within our primary care setting.
Yeah, you can hear a lot of similar themes that also match the national evidence for why behavioral health integration has gotten evidence for the last 20 or 30 years, that there's just not enough mental health workforce. There's never going to be enough psychiatrists and therapists, and the wait time to get into an appointment, and then you're in rural places around the state. So there's long wait time. Then you refer, patients don't want to go, they don't want to go to that other building. So having counselors inside the office, but also having your whole staff being part of the screening and acceptance of addressing and asking about emotional and mental health symptoms or complaints or issues. So you're hearing a lot of similar themes being solved in some different ways. One thing, you probably heard every person say CPC plus, and two things that went with that was, I won't say it also happened in my system, but we had to do it. It was written down. You had CPC plus required it, and so we're all really good students, so you're going to do what you have to do. But also there was funds. Several people have mentioned there was funding to pay for and help them, then use their own creativity. So some of you have already kind of mentioned some of this, but would you now talk about what the challenges that you faced in trying to implement BHI? How have you overcome it? What are some of your successes? You've already said some of those, but if you can expand on that. The challenges and the successes.
Well, I would say I had two challenges. Number one, I was a one-man band with all of this. It was just me trying to implement all of this. And we have 9 providers, 16,500 attributed patients. So I'm like, how am I going to make a difference? I can't see everybody. So I started to make sure that there was resources all around our clinic. I I created with one of my assistants a support flyer that was in all the rooms that had support groups on many different things, even social needs like transportation issues. I made sure we had the crisis hotline card in all the rooms. Even I made a card that discreetly someone could grab that talked about the women's shelter and elder abuse. So I wanted to, at least there's resources all in the clinic that were easily available. And number 2 was I had some physician pushback to BHI at first. Most of them were on board to like, go for it. But one was like, I don't think so. Because I'm like, hey guys, I want to start seeing patients for free and giving them hour-long sessions, and we're going to talk about depression, anxiety, and whatever else. It's going to be great. And one's like, I don't know, like, you cannot diagnose people and you cannot prescribe them medicine. Like, what are you going to be talking about? This could be a liability. So I'm like, well, so I had to prove to him and prove to others that I was working within my scope of practice as a nurse. So I created a patient action plan form. I had basically a workflow that I did for all patients, and also for him, I documented everything I did, and at the next business meeting, I'm like, this is what I do. We talk about what their issues are. We create patient-centered goals for what would help them the best. And, if they have questions about their medicine, you have already prescribed, of course. I will answer medication questions because that's also within my scope of practice, is just patient education. So that was an interesting hurdle, but it took time for them to trust me and to refer patients to me. So successes, just having depression screening for everyone 12 and up as a routine thing for our clinic is huge. My sister, she was one of the 45 to 50% that went and visited her PCP within a month before she took her life. And was any type of mental health questions asked to her? No. And it might have made a difference or it might not have. But I love that now that's one of our check-in processes, and the nurses know to scan the PHQ-9. They know what to do if some of the questions are answered really positive. They can ask me. We have tools in place and guidelines in place. Another success is just personal success stories. I remember a couple years ago, there was a girl about my age that was just in crisis. A family member had died. She was the sole provider for 5 of her half-siblings, and she just didn't have anybody. So I saw her quite a few times, and we created a care plan together for what she needed to get through this hard time, and it helped her so much, and I loved being able to just listen to her and be there for her, because she couldn't afford or have time to go anywhere else. So those type of patients that I was able to help a little bit get through a rough spot, those are my successes.
I think, I'm coming from a perspective, I'm a small practice, so I'm a physician owner and have to look at finances, and so that's the big one, is how to make sure that I definitely want somebody in full-time in my clinic now, especially I've tasted having Avis, our student, through this project. There are 3 days a week, which that's, she graduates here soon, so we've got to change some workflows. But so that's a big challenge. Is number one is making sure that costs are covered. I'm not needing to make money on this. I just want to make sure I'm covering my cost, and it's definitely a need. I've had staff turnover lately. I don't know about. I've heard that. I think across the boards that I've had a major staff turnover. I've had staff that had graduated from college. I hired them. They became medical assistants and then nurse LPNs and now RNs, and I don't need 5 RNs in my clinic. So I've had this major exodus of people that they were with me for a long time. Now they're RNs and they're working in the ICU and other places. So now all of a sudden I have staff who aren't used to workflow, having to reintroduce some workflow, And just in the busyness of my day, I get used to having people doing that. It's a team approach, definitely. I can't do this by myself. I rely upon my team to do the PHQ-9s and the GAD-7s, and when all of a sudden that's not being seen at the front desk and that workflow is implemented, then they sometimes get out of my clinic without having that happen. So those are to the bigger challenge. And then just in DeQueen, Southwest Arkansas, having available clinicians or counselors, here in Little Rock, I would think I could probably easily put out an ad and hire somebody. That's not necessarily the case, and making sure they're a good fit for the clinic. But we've had, success story with Avis. She's the student I have right now, and we had a patient that's been to the clinic. The patient had needs where the sister, they were living with the sister, had to have the sister with most of the visits, and so we never had the sister and the patient apart. And the sister was a little bit controlling. By having Avis there, we were able to basically get Avis in the room without the sister, and the patient basically revealed that she didn't want to live with the sister, but she didn't know how to say it. And so we were able to basically go back in and talk with the patient, and the patient basically said, I'd rather go live in assisted living than live here, the house. And I don't think that would have been revealed without having that one-on-one meeting apart from the caregiver. And so that was just one of the success stories that really, really stood out. And I know without that there, I don't know that we would have ever had them apart and been able to pick up on some of that. And so that's one of few, I'm sure, that others could tell you, but that's definitely a need. I think in every clinic. I'm so appreciative of the Blue Cross folks here in the room helping be a part of that, and Patty and Kim and the whole team helping make that possible. But and I wasn't aware of, I wasn't thinking to say I wasn't aware, but I'm aware that, say, obesity has a behavioral health component, but I've had Avis helping do some, I do a lot of obesity counseling, and I see the accountability side of it. I don't think there's anything special I do. It's just the accountability when people come in, knowing week after week, or maybe every couple weeks they're going to see me. It helps them sometimes think differently and make some changes, and I've had Avis start helping do some of that as well. And so that was kind of expanded my mindset on what behavioral health integration can do. It's not just the depression and anxiety, and there's even more. I'm wanting to help do some medication-assisted therapy, and so I'm looking at having all that a part of the clinic and expanding what we do.
Cool. Access is, as we talk about problems, access, which has been alluded to, but if a patient is really in a crisis and has to wait 10 days, 15 days, 2 weeks, a month, so I would think that's probably been the biggest challenge. As we were tampering with, this is a sad story, as we were tampering with integration, I had to give up my office because we didn't have space. And y'all don't know me, but I didn't want to give up my office. And that was on the Little Rock side, but we didn't really have the space on the North Little Rock side. And so as we're thinking through integration, and you don't think about stuff like that, just where are we going to put this person, because we try to use every single piece of our space in our offices. And then I got to be careful with this, because Alicia's already deemed me to be the bad child up here, but anytime we implement something, my father is going to ask me, how do we get reimbursed for this? And I don't know if we have figured that fully out, what the full reimbursement looks like for this integrated care. And I'm not saying that's not going to hinder care, because we're going to do it, but I do think that is a challenge, and I think that's something as an industry we have to look at. And then the last piece, because I met with my team before I came over, and Medicaid is a challenge, and particularly as we have a large Medicaid panel, and so there's a demographic that I think is suffering because they have Medicaid, and many of these behavioral health providers don't take Medicaid, and so again, that falls back upon our staff to think through what resources, where the bridge that we can sort of cover until we can get those folks into some spaces. But I think those are probably the major challenges. And then, I would say successes. I mean, being in this room right now is a success. Thinking where we were prior to CPC Plus and having a relationship with Dr. Gibson and Kim, actually walking through not just me and my care manager, but really working with our providers, I think is a huge plus because I think it's sort of started to cultivate a new culture in our clinic. Our saying has always been is quality care for quality people, and you gotta stand up for that in the downslopes and on the peaks. And so having that culture of every patient should get quality care regardless of what insurance they have or what diagnosis they have has to be a thought process, and I think our culture in our clinic is starting to evolve into that.
Mm-hmm. So I think for us, as far as challenges, when I think about the challenges we've had, I think our successes have kind of come out of those challenges in a lot of ways. So challenges initially are, how is this workflow going to work? How are the medical doctors going to know how to refer, how to get people to behavioral health services? Varying comfort levels with the physicians on the medical side and the nurse practitioners in dealing with behavioral health conditions. So, some of them may be more experienced. They've treated a lot of depression and anxiety, and some may say, I'm not comfortable at all doing that. So at the organizational level, looking at that, looking at space, like you talked about, and then ways to provide for really challenges on the patient side. So things like transportation. So we now have our own transportation, and things like dealing with, I've had lots of patients say, I can either get my medication or I can go to the grocery store and get food, but I can't do both. So finding, implementing care managers to help with food banks and different community organizations and different resources for patients so that they don't have to make that choice. Working with pharmacies on, pricing of medications. Again, every little bit helps with patients. And so a lot of those patient challenges we've worked as a team, and I would say that's kind of when I go into the successes, I would say our team is amazing. I really have to say, they are phenomenal. That's the nutshell. But what we do is a hard job. Whatever you do, if you're in quality or a physician or whatever you do, it's a hard job working with people, and behavioral health integration is not an easy task. I think you can tell that from all of us up here today, but I got the team together and I said, what do we do well? And every single one of them unanimously at the same time pretty much said, we take care of people. We give them quality. We give them the best of us. And I think that is pretty cool. But, and just that team mentality flows through the medical side to the behavioral health side. Even today, like I have some team members here, and Sadie's our director of operations, and then Dr. Clifton's our psychiatrist. They're both going to kill me later for that, by the way. But but they're here supporting me, and that's pretty awesome. And so I think having that internal support and building that communication has been really essential for us. Going back to one of our challenges with some of our providers that may not be as comfortable doing that initial evaluation and screening and management of patients with behavioral health conditions. One of the things that's been helpful to us has been the REACH Institute. I'll shamelessly plug that for you. And again, we're thankful to Blue Cross for the scholarships. I'm one of those recipients, and I'm super thankful for that. It's been such a great course. So if you don't know about that, ask Dr. Gibson, and she can tell you all about it. But it's a great thing to help additionally incorporate behavioral health integration. So I think teamwork, and everybody's kind of said that, is a huge part of success, and working with patients included on that team.
For us, I think at the beginning when we began looking at behavioral health integration and realizing all the needs of our patients, it was very overwhelming, and we weren't really sure where to start. And I think as we continued to discuss it, I could tell that the staff was unsure of what their role would be. Like, what if I'm one-on-one with the patient and this comes up? I'm not really sure how to respond. And so I could see that there was a lot of, uncomfortableness, and they weren't as confident as they were if you're going in and talking to a new diabetic or whatever the case may be. So we took a step back, and I really poured a lot of energy into the staff. ABN has been so instrumental in the training that we have done. I just cannot say enough for Dr. Gibson and Kim helping us with the training and really getting my staff to feel comfortable. And then once we kind of started building that foundation, we're a small clinic. We have 3 providers. We decided we're just going to bite off a small thing at a time. And I think that really building a strong team, getting my team comfortable, getting them communicating with one another, understanding the mission and the goals of what we were trying to accomplish with our patients, and setting that foundation was instrumental to us being able to overcome some of the other challenges that we would come up on daily and weekly. Kind of gave us the foundation to start dealing with those, and we would just try to bite off small things at a time, get successful at it, learn from it. There's a lot of trial and error. So I would just encourage everyone, really, regardless of what point you're at in this process, there's just a lot of trial and error, and that's good. It's totally okay. It's how we learn and figure out, what's going to work. I think that the biggest success to me has been the response from the patients. It basically made me change the kind of mission statement of our clinic. And our mission statement now, it's on a big whiteboard in my office. Everyone hears me say this a million times at the clinic. But our number one focus is improving the physician-patient relationship. And our second focus is improving the individual patient's health outcome, getting the best health outcome we can for that patient based on their barriers and what they're dealing with. And we really filter everything that we do through that. So the successes that we have seen with our patients, our groups have been very successful, the diabetics, and we just recently started doing a group for grieving, which has been really, really good. Seeing my staff be more comfortable dealing with someone that might be suicidal, or all the other challenges, and then seeing my staff pick up on little bitty things. So a couple of weeks ago, one of the girls was covering for someone at the front desk. She came back to my office. She said, "We have a couple checking out, and they do not need to drive home." And so I said, okay, you go make sure that they don't get in the car and start trying to drive, and I will figure out the rest. So I go into the billing office, I grab a biller, I say, you're going to drive them home, I'm going to follow you so that I can get you back to the clinic. That was such a huge call when I got out there and realized the condition that they were in and how they managed to get themselves to the clinic. I'm really unsure. They were so grateful. They were very responsive to my staff member. She had gotten them to the car, gotten them in the car, but not in the driver's seat, and was just standing there waiting with them, talking to them and chit-chatting. And then we got out there. We took them home. We get that, take them all the way into the home. And then I'm like, okay, how are things going here? Do you need some groceries? Do we need to go to the pharmacy and pick up any medications for you? And they're like, we'll be fine this afternoon because our son and daughter that live out of town should be here this afternoon, but we haven't been able to go to the store or get our meds for the past 3 weeks. And I was horrified. So we made sure that we got all of our contact information in their phones. They knew that they could reach out to us for these types of things. And then I went right back to the clinic, made sure that our nurse practitioner, it was on her list. She was going to be calling them making that afternoon to make sure that their children arrived. If they didn't, then we would be able to take another form of action to help them through that gap. But Those small things give you so much information. And so that's why I just, encourage and say to everyone, what I tell my staff, when you're dealing with that patient, whether you're checking them in, checking them out, intaking them, dealing with their billing questions, whatever, I know we're all busy. We all have 100 things going on in our mind. We're balancing all these plates. But please focus on the person in front of you and just pay attention to that person for that moment and really, really, really hear what they're saying. Because that has not been the only time we've taken someone home and figured out we had a really, really serious situation on our hands, and we were not picking that up from them coming in and being in the room with the nurse and the doctor and everybody that was coming in contact with them. Like some of these things you find out in an incidental way. And so when you have a staff that's really trained to listen and pick up on those things, it's just huge to what you can accomplish one patient at a time.
Okay, I think that for prime care, I'll start with our successes, have definitely been that we've increased access of care to our patients. And the teamwork between counselors and providers within the same facility really help outline to the patient why it's important that they follow with both of them with the treatment plans. That has been a big success for our patients. Convenience, they're coming to one place, they're getting wholly treated. That has been, excuse me, my phone just fell. That has been a big success. Outside of our patient, this does benefit our patients, but when our patients come in crisis, because we have our behavioral health team and the work that they've done with our team, like I said earlier, it makes them more comfortable with handling patients that may be in stress, under stress, or in crisis. So that's been a big success because it's not only given to our patients, but it's given to our entire team how to handle certain situations. Complications for us, we have been very fortunate to have the incentive program help. That has been a big part. But we want to make sure that it's going to be sustainable past that. So we have been tracking different codes that we've been told are integrated behavioral health codes. Try this code should work. Try this code should work. So we track them, and part of my responsibility is to see what is working and what is not working. So I know some of y'all talked about the financial aspects of it. So us looking at that really closely, and I even had like a little shot here today, our last 2 codes that we've been trying, different payers may pay between 60% and 0%, some of the payers. It's inconsistent. It's inconsistent, and it's not a lot typically that our mental health providers can get paid within a primary care setting. There's issues with billing same day for services. There's issues with it being a medical facility and you're billing for behavioral health services. There's an issue with that. That's pushed us to have to do, we want to take care of our patients. It doesn't matter what insurance type they have. So each one of our counselors have an allotment of pro bono. Some of our counselors only do pro bono patients because we know we're not going to be able to get compensated for it. A lot of times the patient cannot afford those services if they have high deductibles. They cannot afford those services if they are self-pay. So we've managed to be able to do pro bono, bill for what we can. We don't hold the patient at this point. We're not holding the patient responsible for the excessive costs after we bill the insurances and stuff because they are unaware of, I'm so sorry, they're unaware of the situation. It's not their fault. Because they came into a medical facility and they got whole treatment with counseling and medical. So there's complications with that. Verifying insurance. for behavioral health has been a struggle for us. And maybe if somebody, I'm so open, but if anybody has any better ways, I want to help my team. I want to help the patients that come in. So verifying behavioral health benefits in a medical setting typically means we have to call those in. You can't just view it through the portals. Typically, it's not accurate, is what we have found. So you call them in, but that can take a really long time on the telephone for one person to verify benefits for one patient. We're talking like a half an hour. I'm not exaggerating. So that's been a complication. We contracted with an LPEI to do some, he works full-time in one of our medical facilities, but we credentialed him with Medicaid, and the process took 1.5 years to get him credentialed with Medicaid, so that we would be able to have somebody that could see our Medicaid patients and could get mental health assessments done without being on a waiting list for 5 months, 6 months. Little other things are like the process changes. When you introduce something new, every time there's going to be glitches. There's going to be, okay, well, what am I supposed to do with this? I will say I agree. So many successes came out of some of that learning together. But so like some of our medical providers, they're like, well, this is not what I was trained to do. I do not understand what you're asking me to do. You want me to bring this person in? But I normally talk to my patients about that. I normally take care of that. We got a lot of that pushback at the beginning, but once they started to see and they built their relationship together, it really benefited the patient a whole lot, and our medical providers too. So I think that's what I have. There have been great successes. It's not something we would turn around and not do again. Then that's all that I have to say.
Thank you, Christina. All right, so as you can see, this is not an easy process, right? There's definitely a lot of barriers, but there's a lot of successes. And as we listen to these patient stories, that's what makes it all worth it. I think about, we're all health consumers, and so when we go in for our health care, there may be times that we're in need, and if we could have one of these services, it's going to be really important, and it changes our patients' lives, and it changes our lives. All right, so with that leads up to, could you talk a little bit about how has incorporating behavioral health integration into your organization added value?
Well, I think for my clinic, it has made us a more comprehensive whole person clinic, which a lot of the value-based programs encouraged, which is the best care for the patient, not delineating physical health and mental health as two different things that you have to go to two different doctors. So the value is better patient care, better patient outcomes, and I just hope that for my clinic, my dream is that too, we could hire a behavioral health consultant and be able to afford that person financially so that our patients would have that resource available readily. So it's made our clinic so much better, and what we all want patient care to be is patient-centered with the best outcomes.
And just, coming from a holistic approach, just if we can get another aspect of, not just their diabetes or their blood pressure, their mental health, it's valuable for those patients when they can get treated, have reduced anxiety, reduced depression, what it could be weight loss. And so that's just the more I can do a one-stop shop and not have to send them an hour away, that's just more value for the patients and our staff. We get the benefit of seeing people improve, and whether that's a smile or a thank you. We can't help them all, but we can help. We do what we can to help those that we can help, and and that gives us the benefit knowing we're helping.
Improvement of workflow would be one, and I think it's organically forced us to pay attention to the patient differently. And then I would just say that, you know, in short, it has improved quality. The delivery of care is improved the delivery of care for our patients as a whole. So.
I think for us, that's a really tough question, but there's a lot of value, and I think our patients feel comfortable getting, you know, behavioral health services and their medical care in one location, so that's great. But also, it's opened up the process has opened up so many things that you maybe would have never addressed in, you know, another kind of lifetime, I guess. But, you know, just the thing with some of our staff members incorporating into processes as they're being implemented and having input and engagement into, you know, all of our clinics. And I mean, that's just a pretty exciting thing. So beyond the patient value, it's also been valuable to the organization as well, and really been effective as far as helping, you know, going back to what Dr. Maddox talked about earlier, a lot of those burnout things, it's really brought a lot of those things to light and allowed us to operate in a way that's beneficial to our employees as well.
Yes, I think that it's brought a lot of value to our clinic. I think that our patients feel it. We get the feedback, you know, they're like, the clinic feels different. I think the culture of our clinic has changed. The growth in our staff has been so exciting for me and for Dr. Cobb, who owns the clinic. I mean, we've just been blown away when you really take the time to give people an opportunity to grow. You sit down and with the staff individually, what would you like to work on? We can't make your day perfect, and we can't let you work on what you want all day long, but if we can give, you know, tell us some things that you're interested in. And it's really fun to watch the staff as you develop this and you start doing things differently, and you're like, oh my gosh, I thought I was pretty good at strengths and weaknesses with my staff, but I had no idea they would fit into this niche so well. And then you see them blossom when they're able to spend time, part of their day, doing those things that they really love. And so we have an amazing staff. I could not ask for better. I could not ask for more compassion and caring for the way that they really engage with our patients. You know, primary care, most primary care clinics, you do have family members coming. I mean, it is family care. And so just seeing the growth with our patients, with my staff, the interaction and engagement between the two has just really blown me away. I'm a little analytical, so some of the things the care manager was bringing to me on a regular basis, I was like, I don't know about that. But she prevailed, and she was correct. So I'm giving you credit for that right now. And it's just been amazing to see the growth of the staff and the patients, and in the success stories of the patients. And we are planning on bringing on a behavioral health consultant part-time to our clinic to be able to really start working on taking this up to the next level. So we feel like we have a foundation now, but we're getting kind of our creative juices going, and we got a lot of ideas that we've been tossing around the past couple of months, and so we're ready to roll up our sleeves and take this up a notch.
I would definitely say that we have found a lot of value in having counselors within our primary care clinics. Yes, for the patients, several things that they are being treated for on the medical side are connected to behavioral health. It has been made very clear to us on that side, but also to our staff, because when we're human, we are going through things too, but when we have counselors within the facility, they know how to handle that too. And so they've even brought even more of a blessing to our facilities in that kind of a way. So value for us in all the struggles and all the other things, the challenges, it's been worth it. So definitely.
The thing that really hit me listening to that is what our first speaker said when she was talking about change and teams, and And she gave that little diagram of forming, storming, norming, and performing. And so even though, everybody may not have all the aspects that you could have with BHI, they've made so much progress and already gotten value. And so there's performing there. So I'm just glad I could remember those 4 words.
Absolutely. And, I have to say, we have worked with each of these organizations over the past couple of years, and to watch your growth has just been amazing. And I just want to say I'm so grateful to have been part of working with each of you. So thank you for all you do. You do amazing work, and it's hard. And we've been through a pandemic. We've been through a pandemic the last couple of years, and look what they've done. It's amazing. And so I think that it's important to know, if we can do this in a pandemic, think about, as things start settling down, what we can do. Okay, I am mindful of the time. I do know that it's a Friday afternoon, but I also want to give you an opportunity to ask some questions of our panelists, any questions you may have about behavioral health integration, something you might be thinking about. Now's the time.
I'm going to add, it's not so much a question, Kim, but something that I think has been mentioned up here. Arkansas Blue Cross and Blue Shield will be celebrating our 75th anniversary this year, and a part of that celebration and our commitment, there will be mental health first aid training. Probably a lot of your clinic staff may have already gone through that, but it's totally free. If you're interested, for yourself, your staff, your family members, if you'll contact on our website, it's on any of our retail locations, so it's across the state, and I think it's very relevant to some of the work, and many of you have talked about having your staff ready for people when they present. So that is available, and just wanted to make sure everyone was available.
What a fantastic resource. Dr.
So they know 2 hours online, and then afterward it's a one-day course with lunch included. I think it's like 8 to 4.
Okay. So everyone after this, get on the Blue Cross website and look for the mental health first aid training.
Hi. Okay, I'm an LCSW, and I've heard some of you talk about having interns in your clinic providing behavioral health services, and I'm wondering who's supervising those interns. That's you. Okay. I had heard, I know some of you said you had
How many?
counselors, and I heard only interns, so that's why I wondered.
Thanks for that lead in, because my thing is I'm one of the liaisons for a couple of your students, Michael and Avis. And I want to thank you all, because some of us started back in CPC Plus and PCMH, and it's grown into this wonderful, vibrant community program that's really out there. And I think the supervision of students in Euler and ASU in Fayetteville have really committed to this project. And I think we at UAMS have been doing it for a while. It's really wonderful to have ABIN being able to broaden that with Blue Cross's help, to find the clinics, to really train the next generation, because they're not getting it at school, because this is a new thing. New in some ways for Arkansas, but been around for more than 20 years or more. And I think it's a very vibrant thing because students are really excited about it. I'm hiring 3 of Euler's grads at UAMS to do this work as well. And we just need more clinics to take your dive and your leadership to go in, because I think that's the thing, is trying to get clinics and physicians to really value that. So I really appreciate your sharing all of that information, because I think you are the power behind it to really make it grow across the state. So I appreciate the work that you're doing too.
Absolutely. And to answer your question specifically, so Caitlin Johnson, Caitlin, stand up, please. Caitlin Johnson and I are providing the supervision, and so we're meeting with students. Excuse me. We're providing 1 hour of weekly supervision, and then we're providing them also group supervision, where they're doing case presentations as well as didactic presentations, and so they're able to learn from each other, learn from the different cases, and talk about that. But we're providing the hourly, weekly supervision.
It just sounded like it was almost independent based on what I was hearing, and I'm like,
For practices that want to integrate behavioral health, what would you say is their first step they should take?
I'd say reach out to Kim and Dr. Gibson. Yeah, I mean, they need a counselor in the office, and just have, I mean, I think from my standpoint, somebody at the office can say, how are we going to get this paid for, and is it going to be covered? And, you know, yeah, I don't have a Derek, unfortunately. But I mean, yeah, we just have to know, you know, the need is there. The need is definitely there, and you know, we can't even measure how many people don't go to the ER or don't go to the hospital by the work that's being done, and that's saving, you know, that's what value-based care is all about, is trying to reduce those. And so and the data is there. I think it's one for every dollar spent, maybe $7 saved, 6. I mean, that's a big deal. And so I think we all could benefit from it, but it's having in the space. You know, I've got a 100-year-old building. I've got plenty of space. I've got space for 5 or 6 counselors if I could, you know, put them all in there. But not everybody does. But I think getting that, just where do we go? That's the deal. Is where do we go next? How do we connect to the clinics that want this, to the counselors that want to go to those clinics?
I'd just add, just really quick, it is a different business model and a different way we're providing care, and so being very intentional about your clinic in itself, your makeup of your clinic, and just thinking through that. So this is not something you just go haphazardly in. I think, you know, working with Dr. Gibson and Kim can sort of help you think through that, but being very, very intentional from patient walks in, patient walks out kind of process, and work through those workflows. And yes, Derek, or I call it my Loretta. Loretta writes all our checks, so nothing gets past Loretta, but understanding the business side of that, from reimbursement to where there are opportunities to get grants and other types of funding in your clinic. So those things are out there as well.
I think also just starting somewhere. Each clinic is unique in their patient population, so talk with the people that you work with, find out what are the consistent challenges they see with patients, and it gives you a good springboard to kind of evaluate what types of actions. For us, care management was one of our first things. That's so huge, such a massive piece of all of this, and I probably didn't talk about it enough today, but I think that's always, if you can't do the therapist, you can't do, you know, all these other providers, care management's a great place to start.
I agree with that. I think that care management is a great place to start if you're not in a position that you can, you know, hire a behavioral health consultant or a social worker or a counselor, and you can really jump off of that. Like, you can make care management anything you want it to be. I mean, there is so much opportunity. And the other thing that I probably did not mention earlier is really developing a good population health management system in your clinic, in the way you monitor things. So I feel like for our team, I have a very strong care manager, but I also have a girl that is my population health data girl. And she's not just like running reports, how many people have this diagnosis. We have all of the documentation run through her. So she's really looking at who's going to the ER, who's going to the hospital. She'll come to us and say, hey, we had 10 people in the past 4 months go to the hospital because they fell. What's going on here? Because we feel like we do really good screening with that, and that really is something high on our list. So we had to pause, take a deep dive into that, figure out what's going on here. Is there any common denominators or something that we're missing here? So she brings a lot of stuff to the table for us to evaluate, and that might be a good place to find something to start with. But start small. I mean, you can really start very small so that you don't overwhelm anybody, and pay attention to staff fatigue. So just start small. You may literally just pick 2 or 3 patients that you know have some really huge barriers, and you just put the resources towards really trying to help them out. So small, watch for staff fatigue, population health, and jump off from care management if you can't just jump into the deep end of the pool to start with.
So I'll just be quick. The one thing that Prime Care really has done that's pretty cool is that they've opened up what they've done to other people when they ask other clinics. We want our whole communities. We want people to live better, so and to be better. Part of that is sharing what works. So anytime Prime Care Medical Clinic, you could call, you could ask, you're like, hey, can I speak to your CEO? Can I speak to your quality care person or whatever? But we would, if it was something that you wanted to look into, or you had a specific question, or you hit a roadblock, we're open to share what has worked, what hasn't worked. This is how we started. So a resource, we don't mind. We're still learning too.
So I would just say, if you're starting out as a clinic, you need to find a behavioral health integration champion. You need to find someone that really really believes in this program, someone that is going to be the motivator to change. And that might be a physician or a nurse or an MA, but someone that wants this to happen. Because to be honest, some of my other care coordinators haven't really dived in as much as I had, because it's not something that they really are passionate about. So find a champion for behavioral health, and you might already have that person, or you might need to hire someone to kind of spearhead this work, because it's a lot to try to transform a clinic into having behavioral health.
It may be time, so I'm good with not asking my question if we want to go to. Okay, they didn't tell me I couldn't ask questions, so I'm going to ask real quick. One or two of you, just to conserve time, could you speak on how you're measuring success outside of patient stories, which are very important, but how are you showing your leadership quantitative data that shows that you're moving the needle? Are you using your EHR and running reports, or using spreadsheets? I know in my experience as a BHC, it's how do you do it, and then how do you know you're doing good at it? And that's what my leadership wants to know. So how are you guys doing that in your setting?
I think I mentioned earlier, we pull from our EHR. We just pull different. Can y'all hear me? We do. We use the data from our EHR. We monitor and pull that data to see our patient progress, and then also through our incentive programs, they give us great data that we also resource to take and look at for our metrics. So.
We do the same thing. We pull data from our EHR. I will say this is an area that we struggle, just because I am an analytical person. I like spreadsheets and numbers. And so I don't think we're great. That's an area we need to work on. I don't feel like we're great at measuring exactly what's going on, except for just verbal feedback from patients. But we're trying to get better. We're even trying to develop some of our own structured things within our EHR. So that's something that you might not think is a typical structured thing. It's really just a comment. We can get it in a structured box, so we can basically run reports and see what certain responses were. But it's definitely something that we're trying to improve. We do struggle with it.
That's an area that we've also been working on, and that's one of our kind of core things that we're trying to hit this year is that very thing. So we use spreadsheets, reports, all the things they've talked about, but also one of the things that's been somewhat painful this lately, we've restructured some of our templates in our EHRs that allow us to better capture some of the data. And so, we had all of our providers were involved in that and had a role in that, but it's a little painful to roll out. But what we found was that it ended up being way more efficient. And so our therapists are super happy because they said they spend half the time documenting now. So it ended up being, it's one of those challenges that ended up being a success so far. I'll let you know how it goes later on.
EHR, and then the report we got to get to you.
Yeah, that was a plug.
Which which force, you weren't going to mention that, which forces us. Well, but the report we get to you, I think, is useful because it gives me sort of a framework to go back to the staff and say, you know, this is what I got to turn in to Kim and Dr. Gibson, and this is what I found out from our EHR, and man, these are the gaps that we, from that report, or what you're trying to extract from us helps me to sort of framework going forward. So.
Yeah, I think the challenge is the subjective data. It's not an A1C or a blood pressure or a weight. I do really good with that stuff. And so, yeah, EHR, and then just if we can do, I'm short-staffed right now, but pre-visit planning, when we know who needs the PHQ-9 or GAD-7, when that hasn't been done in a year or maybe since their last visit. So. But that type of stuff, that's challenging. I'm glad to know I'm not the only one, because I'm a small clinic. That's a little bit bigger challenge for me sometimes than having somebody that has more of a focused workflow.
For behavioral health, it would be PHQ-9 for me. So everyone that is in my care management for depression, anxiety, we do a PHQ and a GAD-7 every time, and we kind of monitor to see how they're doing. And that's one way that I've been able to show my providers that these interventions with self-management and one-on-one support has helped my patients. So, yeah.
I'm going to ask Dr. Gibson, do you have any closing comments?
Yes. I just want to say thank you to everybody for coming. And one of the themes that I'm taking away from today, I knew it, but you can just see it here, is the partnership, and the relationships are what matter. And so you can just hear, as they're talking about their clinics, that although we're focusing on behavioral health integration, we're talking about whole health care. That's what it is. Behavioral health integration is not just, well, let me go hire a therapist or a counselor, but it is taking care of the whole person. And it definitely includes care management and screening. You don't even have to have a behavioral health person in a clinic to be doing behavioral health integration. What this is about is moving toward whole person care. And so getting us all used to asking someone how they feel, and not just about their blood pressure and their diabetes. And you can see the success here. And the success is in the partnerships within the clinic, and you're talking about partnerships with patients. But also, I think a huge victory is partnerships, like just to have all these people talking together, but also to have the payers, the CMS being part of this, Blue Cross has been part of this, there's some other payers, and the universities, the colleges, the training. So everybody working together is this is really the success. And this is about integration. But at the bottom line, as I said this morning, it's about bringing healing to ourselves, to our patients, to our community. And you can hear how the culture has changed some. And I'm encouraged going from here and looking forward to the next step. So just want to thank the ABN team very much. There's a lot of people in blue shirts that they've been doing a lot in the background. They've been meeting for weeks and pulling things together, and I'm really proud of the speakers that we've had. I'm also proud of the audience and the engagement that y'all have given, and really having some outside people come to the state and for us to say, hey, this is Arkansas. And I think that they have been impressed and pleased, and so we appreciate your attendance and your participation and the support for y'all to be here. So just want to thank Kim and all of y'all for being up here.
Thank you, Dr. Gibson. Here we are at the end of the time, the end of the panel. Thank you, Dr. Gibson. Thank you to the panel members. Thank you to the audience. We know it's late on a Friday, and we appreciate your attention. I do want you all to leave knowing that behavioral health integration is possible, and it just takes that one person who's passionate in your clinic to say, hey, I think I think I can do this. And you can start really small. We've heard from a lot of different people here on how they did. You know, we heard from Dr. Mancino earlier, and he said, I'm the dripping faucet. And I think Aben is the dripping faucet, right, for behavioral health integration. And every time you see us, we're going to keep bringing this up. So we want to say thank you. We have a QR code up here. You can scan that QR code with your phone. It'll populate an evaluation. We really want your feedback. We need your feedback. We won't be able to improve if we don't know how we can improve. Please fill that out. At the bottom of your evaluation, there will be a link to your CEUs. We know that's an important part of this, so please click on that link. And again, we want to thank our sponsors. We want to thank Blue Cross Blue Shield for your support today, for making it possible to have a breakfast and a lunch. We want to thank St. Vincent for the use of this wonderful facility, and we want to thank HRSA for providing us with funds to make this conference possible. With that, we hope everyone has a safe trip home, and we hope to see you next year.